Welcome to this edition of the CJs and Podcast. My name is Todd Miano, and I am a critical care pharmacist at the University of Pennsylvania. Today I will discuss my CJs article entitled Attributable Risk and Time Course of Colistin-Associated Acute Kidney Injury. Colistin is a broad-spectrum antibiotic with activity against nearly all gram-negative bacteria. Although colistin has been marketed for many years, an association with potential nephrotoxicity has hindered its widespread use. The increasing prevalence of extreme drug resistance in bacteria such as Pseudomonas aeruginosa and Klebsiella pneumoniae has, however, led to a resurgence of colistin use in hospitalized patients. Unfortunately, the true extent of colistin nephrotoxicity has remained uncertain, which poses considerable challenges to clinicians who are treating patients with resistant gram-negative infection. We thus set out to answer two key questions in our study. First, what is the true risk of acute kidney injury attributable to colistin treatment? And second, what is the minimum treatment duration required to cause toxicity? To address these questions, we designed a retrospective cohort study that compared colistin-treated patients with controls that received other non-nephrotoxic antibiotics. We restricted the population to those treated for multidrug-resistant Pseudomonas, Klebsiella, or Acinetobacter species, as colistin use is generally limited to these types of pathogens. Colistin patients were matched to controls using propensity scores that were calculated from data on 65 baseline covariates. Acute kidney injury was defined according to the Kidney Disease Improving Global Outcomes, or KDIGO, creatinine criteria. Our study population included 150 propensity-matched pairs that had similar baseline characteristics and similar delays to effective treatment. The incidence of acute kidney injury was 51% in the colistin group versus 22% in controls, corresponding to an attributable risk of 29%. Importantly, acute kidney injury was significantly higher in colistin patients by the third day of treatment compared to the control group, suggesting a rapid onset of nephrotoxicity. We observed resolution of acute kidney injury during admission in 44% and 58% of patients in the colistin and control groups, respectively. Notably, hospital mortality in patients who experienced acute kidney injury was lower if kidney function returned to baseline during hospitalization. In an analysis aimed to identify factors that modify colistin toxicity, we observed an inverse relationship between baseline hemoglobin and toxicity risk during colistin treatment. Our study is the first to clearly define the attributable risk and timing of onset of colistin-associated acute kidney injury. Perhaps the most notable finding from our study is the early increase in acute kidney injury observed in the colistin group, which suggests a rapid onset of nephrotoxicity. This finding has important clinical implications. Although empiric colistin could minimize the delay to effective treatment, our findings suggest that such empiric use may be encumbered by considerable early nephrotoxicity. This unfavorable trade-off highlights the importance of risk stratification in these patients. In regions where the prevalence of multidrug resistance is high, clinicians must be familiar with their local antibiograms, risk factors for resistant pathogens, and should consider routine consultation with infectious diseases specialists. Given that most acute kidney injury events were mild to moderate in severity and that they were frequently reversible, more aggressive use of colistin in the empiric setting may be prudent in high-risk patients to avoid the potentially devastating consequences of delayed treatment. Thank you for listening, and this concludes our discussion of colistin-associated acute kidney injury.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.